Hi, my name is Chris Sutton, and I'm going to be performing my video number 1 on C-section. I'm going to perform my machine check right now. So I'm going to want to make sure I have pipeline pressure, make sure there's no crossover. If there was O2 in this pipe, it would be showing at least 50 psi. And then I have my E-tanks here on the back with a key. I want to make sure that those are at least halfway full, and it looks like they are. Okay, now I'm going to make sure I have my ammo bag and also my suction. And then also to make sure I have my apples, my rescue meds, as well as my extra airway equipment. I'm going to go ahead and check my, my flow meters and make sure my Link 25 is working. And I'm also going to do my low pressure check and check my flow meters as well as my my vaporizers. Make sure there's no leaks with both of those. I'm also going to make sure that my vaporizer is full. I'm going to go ahead and ensure I have AC power, and I'm going to calibrate my O2 sensor and make sure my CO2 absorber is not exhausted or desiccated. I'm going to also make sure that my standard monitors and ventilator settings are at the appropriate settings, and I'm also going to check my inspiratory and expiratory valve. Okay, at this time I'm going to go ahead and perform my high pressure check, and I'm going to close my APL. I'm going to make sure that I'm turned to my manual mode, turn my APL valve all the way off. And again, if I had pressure, I would flush. I would push my O2 flush and inflate my reservoir bag. And I would increase the pressure to about 30 centimeters H2O, and ensure, while I'm including my white piece, ensure that maintains 30 centimeters H2O for at least 10 seconds. So let's just pretend it does. Okay, all right. Okay, now we're going to move on to our patient here. Okay, I have my my OB patient who's a 26-year-old female, G2, T2, PO, AO, and L1. She has a BMI of 22. Her height is approximately 165 centimeters, and she weighs about 60 kilograms. She has been admitted to our labor and delivery unit for about 26 hours and has had an epidural in place for about 14 hours already. Her OBGYN is ordering a C-section because of concerns of failure to progress. So I'm going to go ahead and ask her some medical questions. Have you had any issues with, you or your family had any issues with anesthesia in the past? She reports no. Have you heard of anything called malignant hyperthermia? She reports no. Do you currently take any medications? She says no. What did you have for breakfast this morning? She reports nothing, but we'll still consider her a full stomach. Like I mentioned, she has no current medications. She does have a history of gestational diabetes and an appendectomy. Labs, some of the labs that we got a recent CBC, CMP. They were within normal limits, and she just had a type and cross sent. So imaging did show with the ultrasound that the baby appears to be doing fine, but the OBGYN worried about the baby's failure to progress. I went ahead and did a physical and airway assessment, and it showed that she does have a Mallampati score class 1, thyromental distance of at least 3 fingers, upper lipper bite class 1, and incisor distance of 3 fingers. She has a neck length and girth that's within normal ranges, and her neck range of motion, she does have full range of motion in all directions. I did go ahead and auscultate with my stethoscope her heart and lungs, and found that those were within normal limits. And I found that if she needed to be intubated, that she would be appropriate. I also found that the patient, she did state that she has been feeling winded with climbing stairs and walking long distances. So I have determined that this patient has an ASA. She is an ASA class 2. So for the procedure, so we will plan on using this epidural that's already been placed as the anesthetic for the C-section. However, for Plan B, we could do a subarachnoid block. For Plan C, we can do general anesthesia. For the induction medication that I would use for prior to doing general anesthesia would be 100 micrograms of fentanyl, 120 milligrams of propofol, and 60 milligrams of succinylcholine. The benefits, however, of doing an epidural and spinal is that general anesthesia may not be required. She does by not doing general anesthesia, there's decreased stress. Might be a decreased stress response, decreased risk of DVT or PE, decreased risk of ileus, and also improved respiratory function. There are risks, however. Total spinal is a risk. Nausea, we could get into the blood vessel, one of the blood vessels. Permanent nerve damage, as well as a post-dural puncture headache. So I've informed her of all this information, and the patient has consented, or that we are good to go with this procedure. So I've gathered my equipment, and especially for this scenario, since it's a C-section, I've gotten Pitocin, Methergin, and also meds for sedation if we need it. So for the neural axial blocks, I did gather our PPE, epidural kit, spinal kit, narcotics, anesthesia, anesthetics, sterile gloves, crash cart, and upon assessment, I did find, as I was aspirating the epidural catheter, and I also attempted to flush with normal saline, sterile saline, that the epidural catheter was not functioning properly. So I will change my original plan by pulling the epidural and proceeding with a subarachnoid for the C-section. And she has consented with doing a subarachnoid block. So I'm going to go ahead and pull my epidural catheter out completely. Put a Band-Aid on there. I'm going to go ahead and identify my L3 and L4 by finding the iliac crest and following that together, following the Tufiers line. And I'm going to probably go about right here. So now I'm going to don on. I've performed my timeout, make sure it's the right patient, right procedure. And so prior to donning on my sterile gloves, I do want to make sure that this patient has appropriate monitors on. So non-invasive blood pressure, as well as pulse ox, 3 leads, 4 liters nasal cannula, and I'm also going to give her a bolus of 500 mLs of LR prior to going into the OR. Patient positioning, I'm going to have her sit and hunched over on the bed, and also I'm going to have you hunch your back like a cat. Can you go ahead and do that for me? And she's able to perform that for me. Okay, so now for the block. So now I'm going to don on my sterile gloves. So donning on my sterile gloves, and I'm going to prep the area. Okay. All right, you're going to feel a little bit of cold. Okay, put that on. And I'm going to grab my sterile drape using sterile techniques, my sterile technique, and I'm going to go ahead and place my drape on. All right, make sure I have my puncture site in sight. Okay, all right, now that that area has been sterilized, I'm gonna go ahead and prep my meds. So to localize the area, I'm gonna use 1% of lidocaine using 3 mils. And then for my, my spinal block, I'm gonna be using bupivacaine 0.75%, 2 mils, with, in conjunction, Duramorph, 200 micrograms. Okay, I'm gonna drop those meds, make sure those prepped and ready to go. Okay, so now I'm gonna go ahead with the 25 gauge needle and place my local anesthetic. Okay, you're gonna feel a little bit of sting and a burn. It's just gonna localize the area, just numb it. Perfect, good job. All right, good job. All right, okay, so now I'm gonna grab my introducer. And I'm going to use the Bramage grip. As I place my introducer. Okay. All right. Now I'm going to grab my spinal needle while still using the Bramage grip. I'm going to insert it in. Feel some resistance, and I should feel a pop right through. Okay, pop, I felt the pop through, and now I'm just gonna pull out. Still gonna be using my Bromage grip. I'm gonna pull out. Looks like I have some CF fluid. Perfect, we're in the right spot. And I'm gonna be using the, I'm gonna check all 4 quadrants. So I'm gonna rotate, and then I'm gonna pull out my, my internal needle. Still have some CSF, and I'm gonna do that a total of 4 times. Okay, I'm gonna take out my spinal needle completely, or excuse me, not gonna take out my spinal needle completely. I meant to say I'm gonna take out my internal needle completely. Okay, and I am going to insert my spinal block. And so what I'm gonna do first is I'm gonna aspirate for CSF. All right, so I aspirate, I get some CSF, and now I'm going to go ahead and inject half of my medication. Injected half of it, and now I'm gonna aspirate, and I'm gonna inject the remaining medication. I'm gonna aspirate again, and then I'm gonna inject, and I'm gonna remove my subarachnoid needle. Perfect. Okay, and then I'm gonna go ahead and place a Band-Aid on there, and I'm gonna, next thing I'm gonna do is positioning. I wanna put my patient in supine position, put a towel under the right side for left uterine displacement. I'm gonna monitor the blood pressure, my patient's blood pressure every minute, at least until birth, and I'm gonna confirm block level. I wanna make sure it goes at least a T4 prior to surgical start, and I can do that with like a blunt needle with kind of some pinching. And I wanna treat the hypotension. So I'm gonna do that with 100 micrograms of phenylephrine or 10 milligrams of ephedrine as needed. And I'm also gonna administer oxytocin as directed at delivery. And then I'm gonna chart my procedure. Okay, so now that the surgery's done, the baby's out, we're gonna transfer, I'm gonna give report to the L&D nurse. So this is Jane Smith, a 26-year-old female with no known allergies, no significant medical history. She came from the L&D after attempting a vaginal delivery, who then was transferred to the OR for failure to progress and underwent a C-section lasting 30 minutes with a subarachnoid block after removal of a failed epidural catheter. She has an 18-gauge IV in her left forearm. She was stable intraoperatively. She had an estimated blood loss of 800 mils. She received a total of 1 liter of LR, 500 mils prior to surgery and 500 mils intraoperatively. She was also given 20 milligrams of Pepcid and 10 milligrams of Reglan IV preoperatively. Her last vital signs in the OR, blood pressure was 118/70, heart rate 65, pulse ox was 99% on 4 liters nasal cannula, and she had a temperature of 36.5. Orders have been placed for IV fluids, PRN pain meds, early mobility, and routine post-op monitoring. What questions do you have? Thank you.